My name is Arturo Evangelista, and I'm going to present a case that I consider interesting about a patient with an intramural hematoma that, as you may notice, it has ulcerated. Well, this is about a 67-year-old patient, a moderate smoker, about 10 cigarettes a day, hypertensive, treated with amlodipine and 20 milligrams of enalapril. His blood pressure was managed reasonably well. He had dyslipidemia, and he was on a daily dose of 40 milligrams of atorvastatin. And well, the situation is that one day this patient presents with sudden, intense lower back pain that radiated forward to the epigastric region. He went to his referral hospital where they discovered his blood pressure was borderline and he was experiencing pain. The remainder was unremarkable. And well, they did an ECG, which caused some doubts, because it indeed showed an abnormality in repolarization, particularly in the left precordial derivations and accompanied by chest pain, taking into account his risk factors. So doctors thought it might be coronary artery disease, an acute coronary syndrome, and they did an urgent coronary angiography that showed two plaques of 30%, one in the anterior descending artery and the other in the circumflex. It was deemed to have no additional value, and no intervention was performed on these 30% plaques. So, well, it was thought that it wasn't an acute coronary syndrome, so a CT was requested. A computed tomography was done to rule out other diseases. The CT scan showed us these images that, as you can see very well, in a non-contrast CT scan, we observe a hyperattenuated area, a distinct area here, which should raise suspicion of a bleeding aorta wall in the descending aorta. A suspected intramural hematoma. Observe that there are calcium points on the intima here, indicating aortic wall thickening. Additionally, it is noteworthy that when contrast is administered, significant irregularities are observed at this level. Certainly, these irregularities would not indicate a hematoma, but they could indicate pathology in the intima. Thus, the only thing the hematoma shows is the wall bleed visible here. Well, we can see that this image along the descending aorta is persistent, this area of hyperattenuation. The acute hemorrhaging of the aortic wall in an intramural hematoma. And we see these patterns, which would indicate that a hematoma would be completely smooth surface. But we see these sawtooth patterns here, suggesting significant aortic arteriosclerosis. We see here in the CT without contrast this hyperattenuation area in the descending aorta with this plaque identifying the intima of the aorta. This is the aortic wall, and the intima is located here in front, indicating bleeding in the aortic wall, an intramural hematoma. Here, with contrast, we see a questionable image at this level, uncertain if it is a small ulceration or not, but it has no further significance at this moment. We just observe it. This information obtained at the referral where he was firstly admitted. Acute coronary syndrome was excluded, conducted a blood test, and found that the pro-BNP was slightly elevated. But you know that the D-dimer is quite specific. It was indeed notable, measuring 1.209. And it is forwarded to our Center for Assessment of Intramural Hematoma due to the lack of cardiac surgery at that hospital. The patient was admitted to the critical care unit. The patient remained stable at first with proper blood pressure management, and we conducted a routine transesophageal echocardiogram 72 hours after the acute episode. We observed this T. Honestly, if I were unaware of the CT findings, I would think this is aortic atherosclerosis, because we notice a thickening which might be somewhat noticeable. What makes me think it could be an intramural hematoma, aside from the clinical context, is that it shows intimal density here, making it less likely to be atherosclerosis, but this is more suspicious, and in any case, I would have my reservations. The clinical context matters. Unlike the CT scan, the transesophageal echocardiogram can sometimes leave one uncertain if it's an intramural hematoma, the thickening you observe, or it is severe atherosclerosis. It has been exceptionally observed that if there is severe atherosclerosis and if there is also a thrombus, there may chronically be a bit of density that identifies the intima. Thus, we already knew from the CT scan that this should be a patient with an intramural hematoma in the descending aorta. With atherosclerosis also visible on the CT scan, it is quite a minimal pleural effusion due to inflammation, and a left pleural effusion from the same hematoma, which is also visible here. This is not a sign of rupture of anything in this sense, given its small quantity. This inflammatory process is often related to the hematoma, and in over half of the cases, minimal pleural effusions occur that are not related with aortic rupture, and this is important to note. Let me mention this. It is also interesting to see some calcified plaques by 3DT. Observe here that we could suspect a penetrating ulcer behind the calcified plaque. However, this is truly the masking that produces the calcium, which causes an acoustic shadow below. And it is not an ulcer, but instead, this is the masking of the same calcified plaque. I mention this so that in other situations, you won't think there is an ulcer here, as it is a calcified plaque with masking beneath it. The transducer is supposed to be up here. Here behind, the calcium does not allow ultrasound to pass, and we can see the calcified plaque very well here. Look, there are images. This is arteriosclerosis for sure, and this up here is also atherosclerosis, no question. This is not a hematoma. What happens is that no one can say that this part down here, some echolucent area inside here that we see. Well, this is probably the intramural hematoma, and sometimes it is not easy to identify it. Yes, if you look closely, there is a solid line here. That seems to be the part of the intima, and above it is the arteriosclerotic plaque. And here there is an area, a line, which should be the intramural hematoma at this level, and also here at this level. But anyway, I understand that it is important for you to see these images because sometimes not everything is so clear in the intima, and sometimes multimodality is necessary. We also see here an image that caught our attention because you say, well, here it is a penetrating aortic ulcers. If this is the intima, it reaches the adventitia. But, well, in this image we see this. We injected contrast, and we observe that by the transesophageal echo, there is a large area of intimal disruption with a deep ulceration in the aortic wall, a penetrating aortic ulcer. This penetrating ulcer is the same one we saw here, which reaches this area here that is very suspicious that the intima may have ruptured, but it has broken through the intima and the aorta media, reaching this lower area, which is the adventitia, so it reaches down here. Here is the adventitia from the wall of the aorta. Therefore, the suspicion is high that the patient has severe atherosclerosis and intramural hematoma with a large intimal disruption, which is a serious complication in the context of an acute intramural hematoma. The next day, after conducting the transesophageal echocardiogram in the morning, we repeated the CT scan. We noticed that the image that looked a bit questionable here regarding possible ulceration in the aorta had grown significantly during these days. It had reached the adventitia, as we can see here, therefore. This leads us to strongly suspect that it is an active image. It is an ulceration resulting from the rupture of the intramural hematoma during the acute phase, which we know from the article we wrote in JACC, that any rupture of the intima exceeding 3 millimeters, which therefore is not an ostium of any of the arterial vessels emerging from the aorta smaller than 3 millimeters, this is a large and new ulcer occurring within an intramural hematoma. There is a significant risk of aortic rupture since the intramural hematoma may lead to some intimal rupture during the subacute or chronic phase when the hematoma reabsorbs. However, in the expansive phase, when we observe these images during the acute phase, it clearly indicates a sign of a bad prognosis, and we suggest acting on these patients as we published in JACC. Thus, we can observe the images here. We have the image right here. A PET CT was done here that missed this image here in case it was something else. Here we can see that we indeed have this ulcer, the hematoma that ulcerates and extends to this area, which is the adventitia with these two horns at each end, typical of the intimal rupture in the intramural hematoma, here and here, because they were hollowed out. Thus, the patient did not exhibit significant aortic dilation. The ulcer's depth was approximately 10 millimeters, but it had significantly increased from the first to the second study. The patient presented some pain, which was always occasional. Of those pains that one might say, I can't guarantee it's due to acute aortic syndrome or if it's an associated pain. This is not exceptional, and it happens quite often. But we decided in this context to indicate an endovascular treatment because really with our experience, these patients have a significant chance they will rupture when ulcerations occur in the context of the intramural hematoma. We clearly know that this was not an ulcerated atherosclerotic plaque. As the first CT scan did not show this image, there was only a small ulceration. But now it was indeed a significant image of intimal rupture and ulceration below. Therefore, we performed endovascular treatment. The endovascular treatment was successful. It is clear that the area was entirely excluded. Here we can see it very well. We were able to discharge the patient with a stent without complications. These stents have an outlet branch for the left subclavian artery, a branch for the left subclavian artery, which saved us from the carotid bypass. We successfully cannulated the left subclavian artery, and it turned out perfectly. The patient has been followed for months and has not generated any complication and has evolved correctly. Thus, I am showing a case of a patient with severe and universal arteriosclerotic aorta. The patient presented a symptomatic intramural hematoma, first suspected of having acute coronary syndrome, and then the CT scan clearly shows the hematoma, and the image is nice. There's a hint of a tiny ulcer, but for hematoma patients, repeated imaging is essential due to changes. Dissection evolves with severe complications at the beginning. However, the hematoma may evolve very dynamically, and it is necessary to conduct imaging techniques every 3 days or so. We noted that the small ulceration visualized by transesophageal echo had turned into a large ulcer, absent in the initial CT scan, and this was confirmed by the subsequent CT performed the next day. In the acute phase of aortic syndrome, an endoprosthesis was inserted, and the patient was discharged without complications. I hope you found this case interesting. Thank you very much.